Good afternoon, everybody. I would like to talk to you today about a very generic topic something that every clinician will come across in their clinical practice, and that is management of an anxiety state. A lot of our patients, irrespective of the branch, will exhibit anxiety behaviors, and it is important, first of all, to identify anxiety as a symptom versus anxiety as a disorder. So, why is there a need for anxiety management? Because it is the most common clinical situation. It can be either a disorder, as I said, or it can just be a symptom. The lifetime prevalence of anxiety disorders is very high. It is around 15 to 18%. It causes significant disability burden. So the thing with anxiety is that people don't understand the impact it is having on their functional life, the impact it is having on their ability to be efficient. It impacts females more than males, and it is closely linked to the personality makeup. So if you have a type A personality, if you have a person who likes to control, micromanage things, the anxiety levels are always going to be higher. And it has a very strong heritable component. When I say heritable component, there are two things. One is the genetic makeup, and the second is the environment in which the child is being raised. If the child is being raised in an environment where anxiety is very common, it is there are a lot of insecurities, there are a lot of issues, then anxiety is going to be predominant in that child, himself or herself. Now, what are the most common manifestations of anxiety? Most commonly, patients will present with palpitations. दिल की धड़कनें बहुत तेज हो जाती हैं. The second symptom, very important, बेचैनी घबराहट. Funnily, we don't have an English translation for बेचैनी घबराहट. It is the experience that the patient will say, and there is literally no translation for that which adequately defines. So, अतिशय बेचैनी थवी, अतिशय घबराहट थवी. That is what the patients will typically present with. They will present with a feeling of uneasiness, restlessness. They'll pace around in the room. They'll feel like a pit in the stomach. They'll feel very nauseous. They can be tremors. They can be tremulousness of the whole body. They can be sweating of extremities. They're unable to focus. They're confused. There's blurring of vision, blurring of thoughts. And in some rare cases, there's a feeling of impending doom, that as if something is going to, the world is going to end right now. Now, diagnosis. Anxiety symptoms can be fleeting, that is in response to a situation, stressful situation, or anxiety symptoms can be because of an anxiety disorder. For example, generalized anxiety disorder, social anxiety disorder. Now, we'll talk about a clinical scenario. This happened in Sims. It happened a long time ago, around 3 years. A middle-aged man was admitted to the ER and was being transferred to the ward. I don't remember for what he was admitted. The patient had claustrophobia. Claustrophobia is a fear of being in closed spaces, and he did not want to go to the ward in the lift. And the patient had to be moved on a bed, and there was no other way of moving the patient to the ward except for putting him in a lift. And the patient had a panic attack. The patient had a very severe panic attack. He was wailing and he was crying and he was shouting, and he just did not want to go into a lift. So the combination of claustrophobia and being in a hospital scheduled to undergo a surgery precipitated this panic attack in this patient. There were all these previously mentioned symptoms. An ECG was done on the spot, an echo was done on the spot, and everything came out to be normal, and it was finally determined that it's a panic attack. So now, how do we manage this patient? What should be done? How should we go about with treating this? I am not going to cover all the medicines, but I'm going to cover the guiding principles on how medicines are decided, because choosing a medicine requires a lot of information about all the drugs that are available in the market. So as clinicians, it would be easier for us to know the basic guiding principles, and then we can choose a better drug. So there are drugs available to terminate an episode. For example, if this patient was having a panic attack, I need to give a medicine to terminate the panic attack. Once the attack is terminated, the patient can be shifted to the ward. So for terminating a panic attack, a rapidly acting agent is required. For example, if you have a headache, you want to terminate that headache, you want to give an NSAID or a triptan or something of that sort with a migraine. Benzodiazepines are the most commonly used drugs to terminate an acute attack. They provide almost immediate relief. Benzodiazepines are dosed at various levels. Lower doses will terminate the panic attack or will reduce anxiety. Higher doses can bring in sedation and even sleep in the patient. So it is a dose-dependent relationship. Other drugs that could be utilized include a beta blocker, for example, a propranolol. But the role of propranolol is just to mitigate autonomic symptoms. So if the patient is having palpitations, or if the patient has a higher heart rate, then autonomic symptoms can be reduced with propranolol. However, propranolol only has a prophylactic role. In cases of an acute crisis, propranolol is not more effective than benzodiazepines. And when used for short term and under supervisions, benzodiazepines do not have an addiction potential, they do not have a dependency potential, and there is no need to increase the dose of benzodiazepines. So on what basis is how do we decide upon a benzodiazepine? What determines the choice of a benzodiazepine? There is only one thing that determines the choice of a benzodiazepine, and that is the half-life of the drug. Drugs which have a higher or a longer half-life tend to stay in the body for a long time. They have lower fluctuations in blood concentration levels. They have a lower addiction potential. However, they have a higher side effect potential because they are there in the system for a long period of time and will cause residual sedation. Shorter half-life, on the other hand, means there are more blood level fluctuations. Repeated dosing of the drug is required to maintain these blood levels, leading to a higher dependency level. However, the time to onset of action is lesser in drugs with shorter half-life as compared to longer half-life, and there is less residual side effect the next day when shorter half-life benzodiazepines are used. Longer half-life benzodiazepines include diazepam and chlordiazepoxide with a half-life of around 40 to 50 hours. They are used typically in management of alcohol withdrawal patients. Drugs with intermediate half-life, these are very important drugs, are typically used in the management of insomnia and anxiety disorders. So clonazepam and lorazepam are the drugs which have intermediate half-life. And the drugs with the shortest half-life, that is 10 to 12 hours, are used for symptomatic management and acute relief of panic attacks and anxiety states. Such drugs include the all famous alprazolam and oxazepam. All benzodiazepines can cause sedation. Sedation is a dose-dependent side effect. It is not specific to a benzodiazepine. The dose to manage anxiety is different from the dose to sedate a patient. Sometimes higher doses are required to manage the anxiety given the severity of the anxiety, which in turn can lead to sedation. Please note, sedation is not a method of relieving anxiety. It is an unwanted side effect of the drug. Long-term benzodiazepine use without supervision will lead to tolerance and dependence and will lead us to increase the dose of benzodiazepines when the patient returns. In this patient, benzodiazepines that was chosen was clonazepam. Clonazepam 0.5 milligrams that was given. The patient, as I remember, was a little obese. The onset of action of the drug was within 10 to 15 minutes. The half-life of the drug was 20 to 40 hours. It peaks within 1 to 4 hours. It terminated the panic attack of the patient. The patient was mildly sedated, and the patient was then transported in the lift while the patient was awake. The most commonly asked question to me in the past 4 years has been alprazolam. Should we use alprazolam? Alprazolam is a drug that most psychiatrists do not use. We do not like it primarily for the short half-life and the fact that it needs to be dosed repeatedly. The problem is not the short half-life or the repeated dosing. The problem is that patients, once they start feeling better, they tend to self-medicate themselves with alprazolam, and we have no control over their pattern or their usage of the drug. It has an almost immediate effect, requires repeated administration, very high dependency potential, available as an orally disintegrating tablet. It is very important to note that most drugs for anxiety management are orally disintegrating. You do not need to supplement them with water. You can just put them in the mouth of the patient. Even if the oral cavity is dry, they will still disintegrate without the need of water. That is primarily because sometimes panic attacks can be unprovoked. They can happen at a time when there is no access to water, and a drug, whether it is alprazolam or clonazepam, will still be effective in the absence of water. So which drug should I use? As I said, it is a complex choice. It depends upon the patient profile. It depends upon what kind of an effect you want, whether you're treating the symptom, whether you're treating the illness. And clonazepam, in my opinion, is the most versatile drug. It goes from 0.25 milligrams to 0.5. Maximum dose of clonazepam is 4 milligrams. Please do not use the drug at that high dose. It can be used as a sedative. It can be used as a tranquilizer. Commonly available combinations of clonazepam are with escitalopram, so you end up treating the anxiety disorder and the anxiety symptoms together in one combination. My time is up. The last I like to touch is role of counseling. A lot of people send patients saying, "Okay, aap counseling kariye, aap psychotherapy kariye." First of all, when a patient is acutely anxious, there is no role for counseling. The anxiety needs to come down. When we used to go to give our viva and we are acutely anxious, somebody would say, "Okay, don't worry, everything will be fine." Nobody really bought that. I mean, nobody was like, "हाँ, अच्छा, ठीक है, तुमने बोल दिया हो जाएगा." So you need to bring the patient in that mental state first for them to accept counseling or to accept therapy. Good therapy is very complicated. It is something that requires a lot of mental capacity. It requires the patient to interact. If the patient is severely anxious, there is no way by which the patient can interact. So counseling is very, very important. There is no doubt about it, but there is a time and place for it. And the time and place is always after the termination of the acute attack. Thank you.